clear that in Montreal, the first cases and the most cases at the beginning were occurring in neighborhoods that everybody in Montreal knows has higher proportion of people who are racialized and immigrant. And also it was coming out that certain ethnocultural communities were also having higher rates at the very beginning. And there was concern that these groups were going to be facing discrimination and racism as a result, because of fear in the general population. So we wanted to speak with the organizations that work with these communities and represent them to find out about what their experience was on the ground, and also the ways that they were organizing collective support and community support given what was going on. When we cross the neighborhood, like the geographic location of the cases of COVID with census data about who lives in those neighborhoods, it becomes clear that there's higher rates among certain racialized and immigrant groups. And also in our study, speaking with different community groups that work with specific populations, it was emerging that certain of course, among racialized and immigrant communities, there's a lot of differences also, and certain groups within that seem to be having higher exposure, largely related to the type of work that they're doing. So there's a history of specific community groups, specific ethno-racial groups working in specific industries, and it's related to their migration history. So for example, Filipinos who, many of the Filipino families that are in Montreal, someone in the family has a background of caregiving. That's how they ended up migrating here. And a lot of them have healthcare training before they come to Canada. So that this is a community that disproportionately high working in the healthcare sector. And among a lot of Black Montrealers, there's that type of history as well. So on top of people migrating for caregiving type jobs, they also have a healthcare background. And especially in the older generations, there was recruitment of people specifically to work in hospitals and long-term care homes here in Montreal. So those communities, yes, had higher rates than others. Well, I can't say rates because I don't actually have that data, but the community groups were reporting high exposure in their communities. Yeah, I think this is a very important point because obviously race is not a biological category, and there's nothing biological about why any racial or immigrant group would have higher rates of COVID. This is about the social determinants of health. And I think what we're seeing is the effects of racism and discrimination that existed well before COVID, making people more vulnerable to exposure. And I think a very critical piece of this is work. People who work on the front lines in this crisis, which is not only the healthcare system, but also food transformation, the warehouses where when people are shopping online, things have to be processed to be sent to their house, people that do delivery, people that do transportation, all of these groups had to continue working outside their home during the toughest days of COVID. And especially in the early days, there was a lot of focus in the hospitals and long-term care homes of protecting nurses and doctors. It took longer for them to protect nurses' aides at the same level, longer again to protect cleaners and security guards. And who are doing those jobs? It's disproportionately racialized communities and immigrants. So, and then when you go outside that, in the warehouses, in the factories, in the food transformation, in the agricultural sector outside of Montreal, these are migrant populations or racialized. So it took even longer for people outside the healthcare system to have proper workplace health and safety. And I think the fact that it took so long is slightly related to who works there and how much influence and power people have to affect change for protection. It is better now, I think, than it was at the very beginning, but it was a terrible learning curve to go through. And there's still problems for sure. There's more chance of it spreading among family members. At the very beginning, the types of advice that was going out, what to do if someone in your household had COVID, they were saying things like, have that person use a separate bathroom. In Montreal, people don't have a separate bathroom, so this is just not an option. So under crowded conditions, under public transportation that wasn't well protected, under workplaces that are collective with large groups of people and poor ventilation, these are socioeconomic factors that led to racialized and immigrant communities being disproportionately affected. Because overall in our society, those groups are overrepresented among the people who do those types of jobs and in the neighborhoods where those are the conditions that people live in. Two things that happen. I think the kind of like a dichotomy for women's work, that women are overrepresented in the frontline caring professions. So they're overrepresented among the nurses, among the nurses' aides, among cleaners in all of these healthcare settings where the risk of being exposed to COVID was extremely high. So women had high chance of getting infected because of that. But also when someone in a home is ill, it's likely a woman who is going to be the primary caregiver for that person. So also, you know, within a family, the mother or the caregiving woman is probably the most likely to be infected by other people because of the care that she provides. On the economic front, though, other types of jobs where women are disproportionately present, so all the sort of front line retail and restaurants, women work there at disproportionate rates. Women, you know, are often the cashiers and salespeople in stores, waiters and cash people in restaurants, and those industries closed very early on and still to this day have been harder hit than other industries in terms of closing. So women working those jobs lost their income for that. So that's something that is going to have effects for years to come, we think, and it's going to have an impact on women's economic power within households and in society. We think we're still figuring out what that's going to look like. For us, it's really the combination of these things that often come together to make people really vulnerable. And it seems essential that we collect it because these are things that from other research we know make people vulnerable to infectious disease, to having poor reception in healthcare settings, to have more difficulty accessing care. And so if we want to really target our COVID interventions to protect people who need it the most, we need to know who they are and what is it that's making them vulnerable. So like I said at the very beginning, of course, race is not something biological that's making people vulnerable. It's the industries that they work in. It's whether they have, it's whether people have health and safety provisions that are sufficient in the workplace. It's whether people have the possibility to isolate if they do get sick. Can they actually take time off work because maybe they're the sole income earner for their family and they might not have easy access to the income support. So we need to see how these things go together so that when we're planning education, support, protection measures, that they can really be targeted where they're needed the most. And I think in Quebec, in particular, there's a real unease with talking about race. There's a fear of being called racist. And I think some people imagine that if it's just not collected, then it's not, you know, we won't get called racist. But people can tell what's going on without the exact numbers. It's just harder to make good plans without good data. But I don't think it's going to change people's awareness of the fact that there's inequity in the current crisis and that not everybody's having the same experience of COVID, and that it has to do with pre-existing racism and discrimination in our society. In our report last summer, some of the most important things that we raised have been addressed by the public health system and the government by now. And I think that's really important to recognize. Things like doing the most possible to keep schools and daycares open, because the children of the most precarious workers were the ones who suffered the most when they were closed, because of language, because of difficulty having supervision for schooling, and just finding care, you know, alternative care arrangements. And I feel like, you know, I know it's controversial to have kept the schools open, but I think that it really was a protective factor for families with precarious type workers. The things that remain, I think that still needs to be a lot done. One is we need to provide healthcare for all. Right now, if someone doesn't have health insurance, they are protected, they are covered for COVID testing and COVID treatment. But if they go and get tested and it turns out that it's not COVID and they just have regular pneumonia or something like that, they'll end up having a big bill for their treatment. And it also just makes it more complicated for people to get in touch with the health system. I think it would be much better if everybody could just have access to health right now without any difficulty, without any barriers, without having to, you know, reach a certain level of diagnosis. I think that just would be better for everybody. I think that the final thing that is really important is to just keep on top of those workplace health and safety issues, to make sure that all workers have protections, that workers, regardless of their status, can go to public health, that they can go to the CNEST and make complaints if their rights are not being respected. And in all of these cases, that people can do that without any fear of the provincial system being in touch with immigration. So that's really important. In the longer term, if we want to address things like overcrowded housing and poor work conditions, we need to work on kind of discrimination that leads people to be in those positions in the first place, and for unscrupulous landlords or employers to take advantage of people because they know that they have fewer options in general. Yeah, I think that for me, the most important area for intervention is related to work. I think that, you know, even before COVID started, we knew that there were certain workplaces, there's a disproportionately high number of racialized and immigrant communities that had poor workplace health and safety. Under COVID, this is a disaster. And there's still workplaces there people don't have access to proper protective equipment, where there's crowding, where the ventilation is poor. And if we don't address that, I think that it's going to be very hard to get this under control, but it's important in the long term for all kinds of health reasons as well. So I think that proactive health and safety inspections and punitive measures against employers that are not respecting the health and safety requirements are necessary. I think that there can be more public information about what workers can do if they feel unsafe in their workplace. and also what options are there for them if they feel that they may have been exposed or they are infected. What can be done that helps them protect their jobs and have support while they need to isolate. I also think it's really important to look at immigration status, because when people have uncertain immigration status, they're at more risk of having to accept jobs that are bad jobs, that don't pay properly, that have risky workplace health and safety conditions, and they're not in a good position to complain when their rights are not being respected at work. And we know that during this crisis, people's ability to move around has been curtailed. We know that immigration processes have slowed right down. There's a lot of people who've kind of fallen out of status, partly just because of how long it's taking for immigration procedures to go through. People who came as refugee claimants years ago still haven't had their claims heard. So there is, this regularization program for people who have worked as like in the healthcare system as a caregiver. So I think that program should be widely expanded at a minimum to anyone who worked during this pandemic on the front lines, and it should include people who were non-status while they were doing it, and other categories of immigration as well. But really, I feel like this is a good time to have regularization in general for anybody, because it doesn't help Canada to have people that are without status right now. It means they're going to have more difficult access to healthcare. It's just better for public health, for the population to feel secure and able to seek support and treatment when they need it. So I would also say we need a blanket regularization program right now.